Thank you very much for the invitation to start with this panel discussion. I'm going to talk about the cognitive and emotional health in aging with HIV, and I will also talk about the Spanish evidence-based, the nursing guidelines that we published this year in 2025. So I'm Julio, I'm HIV specialist nurse. I'm also a member of the Spanish HIV nursing network in Spain. Okay, I would like to say thank you to the organizing scientific committee for the invitation to be here today, and the BIP Healthcare and C-Health by the economic and financial support for the development of this guideline that we want to present today, and all the Spanish HIV nursing network that probably they listen to me from Spain today. Some sensitive topics will be loneliness and social isolation, anxiety and depression, HIV-related neurocognitive disorders and stigma, that we've been talking today about the stigma as well, just on the last table, about this Spanish national policy that I will talk about the Spanish national policy today. Some conflict of interest, some honoraria for educational purposes today. So coming to start, over the past 44 years, our approach to HIV has dramatically evolved. Initially, the focus was on survival, dealing with a daily acute illness and limited treatment options. With the introduction of antiretroviral therapy, HIV became a chronic condition, allowing people to live longer and age. Today, we face a new challenge, improving quality of life, and HIV is no longer a death sentence, but it does accelerate aging and brings a unique challenge related to comorbidities and frailty compared to the aging without HIV. But what does aging really mean? According to the World Health Organization, healthy aging is not just about living longer, it's about maintaining physical, mental, and social well-being, including the ability to do what we value most. In 2021, the World Health Organization launched the Decade of Aging, Healthy Aging. It's a global initiative to change how we do and how we act, something especially crucial for people with HIV. A clear example of the intersection between HIV in aging is coming from the Atona cohort study in the Netherlands. It projects that by 2030, 73% of the population with HIV will be over 50 years, with a median age rising from 44 to nearly 57. Polypharmacy will be common, and over half of people will be taking multiple medications, raising the risk of drug interaction and comorbidities. Cognitive and emotional health are essential for people aging with HIV. One major concern in this population is HIV-associated neurocognitive disorders, which includes everything from mild cognitive impairment to HIV-associated dementia. Typical symptoms may include memory problems, difficulty concentrating, slowed thinking and chasing behavior. Those aging with HIV face higher risks due to factors such as viral load, lower level of education, psychotropic substance use, co-infections, and medication side effects like neuropathic pain and depression. It's very important to identify the cognitive impairment as soon as possible, because we have a range of screening tools recommended. And also it's very important to routinely evaluate the suicide risk in this population. For that, we have the Columbia Suicide Severity Rating Scale suggested for do this assessment. On the right side, we have a study from the Spanish Society of Infectious Disease and Clinical Microbiology, conducted the study No One Alone. This study is being published in 2025, and it's been developed across 22 hospitals in Spain, and it provides important insight into neurocognitive aging in people with HIV. This study found a high rate of neurocognitive impairment in older adults with HIV, even among those with well-controlled viral load. This result points to the need for an early detection through neuropsychological evaluation and long-term monitoring. And it is important as well to consider the overall mental health challenges faced by people living with HIV. The mental health burden research showed that the 40% of the HIV population suffer from emotional disorders, and about 25-35 have some degree of cognitive impairment. As well, sleep disturbances are reported in the 60-70% of cases, and 28% use psychotropic medications. Depression and anxiety occur twice as often as in the general population, and among younger people with HIV, more than half experience substantial mental issues related to this mental health. This demonstrates a clear need for fully integrated mental health care throughout the lifespan. This slide summarizes the findings of a systematic review carried out by the United Kingdom on the prevalence of psychiatric and sleep disturbance disorders among people with HIV. Looking to the graph, in blue we can see the prevalences among people with HIV, and in red those of the general population. Overall, this data emphasize the urgent need to incorporate neurocognitive and emotional screening into routine HIV care, combined with the early detection, psychosocial support, and interdisciplinary approaches. Aging successfully with HIV meets not only treatment comorbidities, but is also actively preserving cognitive and emotional well-being. Stigma and social attitudes still play a decisive role in the experience of aging with HIV. According to this study, that is another Spanish study, is evolution of the belief and attitudes of the Spanish population towards people living with HIV, conducted from 2008 to 2021, and it's been published by the Spanish Ministry of Health. There has been some improvements in perceptions over time, but stigma remains a persistent issue. Many people with HIV still face discrimination in healthcare settings, in social relationships, and in the workplace, and especially among older adults and vulnerable populations. So the mental health consequences of stigma are significant. High stigma levels are strongly associated with increased anxiety, depression, low self-esteem, and social withdrawal. Many individuals report feeling isolated or reluctant to seek care, which can directly impact both adherence to treatment and overall health outcomes. There is also a well-documented lack of social support and community-based resources, which further exacerbates this psychosocial challenge, particularly affecting other adults, migrants, trans people, and those with limited economic or family support. Here in this slide, we can see at the left hand that the people living with HIV are placed at the center and surrounded by different physical and mental health conditions like depression, anxiety, substance use, chronic pain, etc. And these conditions doesn't occur in isolation, but rather overlap and reinforce each other. Like the other circles that you can see show the different levels of influence. We can see the biological influence like immunological change, chronic inflammation, medication side effects, behavioral like treatment adherence, substance use or risk behaviors, environmental and social like stigma, discrimination, violence or structural inequalities. And the scheme on the right represents the social and structural determinants that mediate the HIV, like mental health relationships, and at the core is the person with their identities, beliefs, behaviors, and psychosocial resources. And then we can see another layers of influence like interpersonal, again, the social support, the experience of stigma or violence or rejection, community like social norms, cultural belief, organizational barriers, or structurals. Now I'm going to talk about the Spanish national policy that is an interdisciplinary project that in Spain we've been developed in 2017, and that brings together, we've been working together with healthcare professionals, managers, and community organizations to improve care for people with HIV and to combat stigma. This project is being endorsed by leading scientific societies and non-governmental organizations, and it aims to reduce new infections, achieving zero discrimination, and contribute to meeting the UNAIDS 95 target. Since 2017, this initiative has created a different range of tools, consensus documents, and an optimal care model for people with HIV, which includes stratification into 7 patient profiles according to psychosocial and clinical needs in order to provide comprehensive and personalized care. A central aspect of this project is the integration of the patient voice by promoting their active role in self-care and service design, so patient-reported outcomes have been incorporated into clinical practice to improve adherence, quality of life, and the effectiveness of healthcare services. So the initiative this year developed the guidance for expert nursing care of people with HIV, transforming these recommendations into practical, structured framework for individualized, standardized care across all country and with evidence-based nursing care. Which model help us to collaborate and integrate care in a chronic disease management? Probably we all know the chronic care model. That is a popular framework that for health system improvements. This model is the essential elements is the 6 components that working to improve the quality of care that we give in. So we have the community policies and resources, the health system organization of healthcare, the self-management support, the delivery system design, decision support, and the clinical information system. So in Spain, we've been working with these 6 components, and in 2023, we designed different tools that allow healthcare professionals to identify and categorize people with HIV. So for one side, we have the segmentation tool for differentiated profiles or groups that help us to categorize people with HIV into 7 differentiated profiles and provides information on the type of priority care that they need. And the stratification tool by level of complexity provides information on the level of complexity of the clinical management of each patient according to their characteristics. So these tools help us to standardize the care and optimize resources. We clearly and easily identify classify the 70–80% of population with HIV into the most significant segments and profiles. We can identify the optimal care offering adapted to the needs of each user, and also we demonstrate which other professionals or disciplines are essential and must be involved in the care. In July 2025, so this July in this year, we developed this expert nursing care guide for people with HIV, and this document explains the methodology used for this creation and represent a total of 64 nursing interventions. And these interventions are organized and distributed among these 7 profiles. We can see now the 7 profiles that we developed with the national policies: person with HIV with comorbidities, in this yellow color, the person with HIV with social needs or poorly adapted, the patient at the first year of treatment or after the diagnosis in an orange color, the person with a psychoactive substance use in a purple color, the person with HIV and with a risk sexual practice with a light purple, a woman with HIV and pregnant, and the person with a good control of the HIV in blue colors. And key areas is being addressed to include adherence and polypharmacy, mental health, comorbidities, combination prevention, sexual and reproductive health, fatigue, cognitive impairment, or health-related quality of life, and social determinants of health. Why HIV specialist nurses are important? Expert nurses have advanced training and competencies. They influence health outcomes for patients and the team. They have a close relationship with all the patients. and they emerge to address complex needs in healthcare. They increase adherence to treatments and monitoring of chronic disease, and they ensure continuity of care and cohesion with interdisciplinary teams. So, our clinical approach as a nurses in chronic disease management for people with HIV and centered in this cognitive and emotional health, the main goal is humanizing the patient care and the early detection and timely treatment for health problems, prevention of modifiable risk factors, and identifying those at higher risk of poor outcomes. So we should use a proactive screening and holistic patient assessment. We have different tools that we can use every day when we looking after our patients, like the Montreal Cognitive Assessment to identify mild cognitive impairment and early dementia, the Patient Health Questionnaire 9 for depression screening, follow-up, and treatment assessment. This includes as well functional difficulty and suicidal ideation. The Hospital Anxiety and Depression Scale. This is a tool with 14 items to identify anxiety and depression and can be used in hospitals and in community settings. The Pittsburgh Sleep Quality Index that measures sleep quality and disturbance over 1 month. The Berger HIV Stigma Scale assess perceived stigma in people with HIV, also is very helpful in both clinical and research settings. And the Audit and the Assist, that is a rapid screening test to identify problematic alcohol use or smoking and substance involvement. We also we can do the emotional support, empowerment of the patient, education for adherence, lifestyle and polypharmacy, stigma and reduction, or coordination with other professionals involved. To give you a clear example of how the guidelines are structured, I just only highlight 2 of these 64 nursing interventions. This is the patient with comorbidities, the patient profile with comorbidities in a yellow color. So we can have the different nursing intervention, and just only to show you, for example, how is structured the guide inside. No? So you can see the guidelines. This is a representative of a visual format, so you can see each intervention. For quality life assessment, the guide describes which tools are used, the key actions required, where and how often to conduct the assessment, and how to record the results. Real-life case examples at the left side, at the right side, show the guide's success in practice supported by expert nursing. And in the case of the cognitive impairment, we have the same structure. So each intervention includes description of the activity, protocol, the timing, the documentation, and examples and recommendations for implementation. And just for finish, I want to give some message. This are conclusion based on my personal opinion. The landscape of the HIV has shifted from survival to managing chronicity, and now to focusing on improving quality of life as people with HIV age and face more comorbidities. Healthy aging in people with HIV requires a holistic, person-centered approach aligned with global frameworks like the World Health Organization Decade of Healthy Aging. The cognitive and emotional health are crucial. Early detection of HIV, neurocognitive disorders, psychological disorders, and sleep disturbance is essential to improving outcomes. However, the stigma and psychosocial barriers are still a major challenge, limited mental health and social support, especially in vulnerable populations or groups. HIV nurses play a vital role by assessing health-related quality of life, cognitive function, and psychological well-being, while coordinating interdisciplinary teams and supporting both patients and caregivers. And to conclude, these guidelines represent a breakthrough for nursing HIV care, providing an adaptable, standardized, and evidence-based framework. So they foster early detection and intervention, strengthen collaboration across different healthcare professionals and sectors, and support evidence-based decision-making across healthcare settings. So this is all. Thank you very much for your listen.